Thank you, Bob. I'd like to thank the Society for inviting me to speak here. The esophagus is a unique organ because it really only has one function. Its function is to transport food from the pharynx to the stomach, and occasionally it has to vent the stomach. And unlike other GI tract organs, it has no absorptive or metabolic or endocrine function. For your oral boards, of course, you're always going to start with a history. And really the symptoms that people with benign esophageal disease present with are those of abnormal transportation. So they either present with dysphagia or reflux, and on occasion heartburn. And although it sounds fairly simple, the investigation can be somewhat complex. When you do the physical examination, of course, you're looking not for esophageal problems, but for the systemic problems of scleroderma, collagen vascular disease, and other endocrine and metabolic disorders which may cause secondary esophageal involvement. It's probably best to remember that the esophagus is pretty simple. It's basically two valves with a pump in between. And so our tests are going to evaluate this pump and the two valves. And perhaps the best test to start with when we're evaluating a patient complaining of either dysphagia or reflux is a barium esophagram. And since none of us really perform this test, and we're only ever putting up isolated little shots of the study, it's best to really talk to your radiographer and ask them what he's doing. And basically they do four things when they do a barium esophagram. They look at the mucosa, then they look at esophageal function, then they want to look at the contour, and then they will evaluate for reflux. And so we talk about the mucosal examination, and that's the first part of the examination. It's always done with the patient upright. They use high-density barium, and they give a little bit of carbon dioxide tablets or powder to better outline the mucosa. And what they're looking for here in a case of manilial esophagitis are ulcers, and here in a patient with a hiatal hernia and a stricture and a Barrett's, erosions and ulcers. You can see how the barium just coats the outside lining of the esophagus to give us good mucosal contour. And here we can see a small hiatal hernia and subtle shortening of the esophagus here in a patient with Barrett's esophagus. And here we can see a polypoid mass, an inflammatory polyp in a patient with esophagitis. So the mucosal examination is the first part of the examination, and it's done with high-density barium and just a very, very light coating. Then move on to study function, and this isn't the best way to study function, but it gives us a gross overview, and it's best done with fluoro, and now most of our exams are done with video. It's done in the semi-prone position, and now they move to low-density barium, and they'll do single swallows, about 5 per examination, and they're every 20 to 30 seconds apart. And here we can see a patient with diffuse esophageal spasm and a diverticulum. And here's a patient after his 5 swallows filling his achalasia, dilated, tortuous esophagus with barium. The next thing they're going to look at is contour. And here they're going to try to fill the esophagus with barium. Again, they do it in the same position, again using low-density barium. And here they have the patient do multiple swallows or gulps. They want to look at the column of barium to see the contour. And then when they clear the column, they'll get another look at the mucosa. And here we can see a dilated esophagus with a stricture sitting above the hiatal hernia and maybe a little bit of an ulcer. So this is an excellent contour study. Here we can see a hiatal hernia and a Schatzki's ring. And here we can see a dilated proximal esophagus, this long, narrow stricture, and really no hiatal hernia. And this is a classic pill-induced stricture in a patient without reflux. And here we can see a mid-esophageal stricture, no suggestion of a hiatal hernia, and this patient was post-operative patient after a prolonged NG tube intubation, and this is a classic view of an NG tube stricture. And here, looking at contour, big dilated, starting to be sigmoid esophagus, the big diverticulum, and you can see the barium getting into the distal GI tract, and that's achalasia with an epiphrenic diverticulum. They will give us a gross evaluation of whether or not the patient refluxes. After they do those 3 studies, they're going to have the patient clear the esophagus of barium. They'll put the patient prone, and then either have the patient cough or press on the abdomen to see if they can have the patient reflux from their stomach. And on occasion, they give them a sip of water. This test is probably only about 40% sensitive for the presence of reflux. If the patient has dysphagia, the examination should include a barium pill. And if the patient has problems with certain foods, such as bread or chicken, they can bring selected solids and mix them up with the barium if they have a specific food that they have problems with dysphagia. Every examination where there's oropharyngeal problems should have a speech pathologist present. Has to be done video with both low density, high density, and selected solids to complete the examination. Many people feel that flexible fiber optic esophagoscopy has really replaced the barium swallow, but the barium swallow is a very, very useful tool. And we limit flexible esophagoscopy and biopsy to those patients in which we want to get mucosal definition, because that's really the role of the flexible esophagoscope. And indeed, it can sometimes give us an idea of things happening outside the esophagus or structure or motility. It really should be limited to a mucosal examination. And here we can see a peptic stricture with severe esophagitis. And here we can see again the tongues of esophagitis here, and an inflammatory polyp sitting right at the squamocolumnar junction. We can see the hiatal hernia distal to that. And we get a very, very good view of the lumen of the esophagus. And here is, of course, EG junctional adenocarcinoma, something that we are more and more aware of with our epidemic of Barrett's adenocarcinoma in white males. Here we see a smooth tapering esophageal stricture. It's a peptic stricture. And sometimes we get a little idea of what's going on function-wise. Here you can see a very, very dilated esophagus, which is starting to get a bend in it. There's no mucosal abnormalities, and this is, if you watch in the esophagus, you'll see there will be only tertiary non-propulsive waves. So by using the flexible fiber optic scope, we can get some idea of esophageal function, and we can also get some views of the structure. Here we can see a scope coming through the esophageal gastric junction, which appears to be intra-abdominal, and with a scope retroflexed in the stomach, we see a big type 2 hiatal hernia. So it can be helpful for looking at function and structure, but its main role is to look at mucosa. And really what we're looking for is esophagitis. And we have to grade that with basal cell hyperplasia, whether or not there's signs of inflammation, or has it progressed to fibrosis or been complicated by the columnar-lined esophagus. And here we can see the distal squamous epithelium of the esophagus, and here's proximal cardia. And you have to remember that in the distal esophagus, there is what is kind of physiologic hyperplasia with these lamina propria pegs sticking up here in this overgrowth of this papilloma. So whenever we do our biopsies, we have to tell the pathologist where they're coming from, because these normal physiologic changes right at the EG junction may be misinterpreted as inflammation. So what we classically see in somebody who has inflammation, and these biopsies and findings are not specific for reflux, they could occur with any inflammation, is we see papillomatosis. Here you can see how this peg of squamous epithelium is a little bit longer than you'd expect. The lamina propria is sticking up here, and there's basal cell hyperplasia. So that's the earliest changes. What they're really looking for is inflammatory cells, and here you can see an inflammatory infiltrate with eosinophils, which makes them happy to call inflammatory changes consistent with reflux esophagitis. Here, we will have to also remember where we're doing the biopsy and tell our pathologist, because the finding of gastric cardia biopsies here, and you can tell because of the mucus glands in here, or fundic epithelium with chief cells and parietal cells, may be the early changes of Barrett's esophagus, but most commonly they're due to misdirected biopsies of the hiatal hernia. And when it comes to Barrett's, what we're looking for is specialized columnar epithelium. And here you can see the goblet cells. And if this biopsy is taken from the esophagus, then that's synonymous with Barrett's esophagitis. Again, you have to be careful of not biopsying the gastric cardia that's involved with a gastritis, because this same finding can be seen with H. pylori. And what we're interested in here, we can see that this is acid mucin. It stains with allicin blue. And so here's specialized columnar epithelium found in a distal esophageal biopsy. And what we're trying to do is to look for dysplastic changes. And here we can see normal columnar epithelium. You can see how those nuclei are all aligned along the basement membrane, how they are very, very reproducible and very, very similar shape with not too much chromatin. And here we can see the beginnings of dysplastic changes. And you can see that they're both architectural and cytologic changes. And you can see that those nuclei now are kind of in mid-position along the epithelium. They're not basally oriented, so they're beginning to lose their polarity. Also, the nuclear shapes are starting to be a little abnormal, and they're starting to get denser chromatin. And this will progress to high-grade dysplasia, which is really intraepithelial cancer. This is malignancy that hasn't invaded the basement membrane. And here you can see there are nuclei spread all the way, even coming right to the top of the gland. And you can see that there's even more abnormalities in the cells, both in shape and contour and in chromatin content. They're very, very dense, and some are very, very clumped. So this is high-grade dysplasia. Probably best not to call it adenocarcinoma in situ. And most people now believe that this is intraepithelial cancer. So those are the things that we're looking for on biopsy. Perhaps the most important test to surgeons who are trying to repair the esophagus is manometry. And I try to point out to our cardiac trainees as they come through our service that this is the coronary cath of the esophagus. You would never really want to repair anybody's esophagus without knowing the manometric studies. And what we're looking at are the pressures in different portions of the esophagus, the coordination of the transfer of pressure, and the motility within the esophagus. And this is an older catheter. It only has 3 lumens. Usually use 5 lumen catheters to study the esophageal pressures. And we're going to look at the lower esophageal sphincter, the body, and the upper esophageal sphincter. And in the 2 sphincters, we're worried about the resting pressure and whether or not there's complete relaxation and how long that relaxation exists. And then we're looking at the body, both at the contraction, the size, the amplitude of the contraction, and whether that's a propulsive contraction. And here is a typical manometric study. Here we can see there's a swallow initiated by the patient, and there's immediate relaxation of the upper esophageal sphincter. And notice also there's immediate relaxation of the lower esophageal sphincter, which is prolonged and lasts till the end of the swallow. And this is anywhere from 4 to 8 seconds long. When this upper esophageal sphincter opens and the wave passes, it immediately closes. And you can see there's a nice progression, a propulsive wave down the body of the esophagus with a nice contour wave that doesn't have too high an amplitude. Atmospheric pressure in the throat. The upper esophageal sphincter is 60 to 80 up to 100 millimeters of mercury pressure. Usually the resting pressure intraesophageal, because it's in the thoracic cavity, is negative. The lower esophageal sphincter pressure is between 10 and 20 millimeters of mercury, and the intergastric pressure is 5 millimeters of mercury. And we can see that we want a resting amplitude of 10 to 20 in the lower esophageal sphincter, 20 to 60 or 60 to 80 in the upper esophageal sphincter. And the amplitude of the contraction wave should be up to 80 millimeters of mercury in the body of the esophagus. Esophageal motility testing is crucial and required for the evaluation of patients with dysphagia to study primary esophageal motility disorders and also secondary esophageal motility disorders. Motility should be considered in every patient being evaluated for gastroesophageal reflux disease, especially if they're presenting for surgery, because you want to know what's going on with the esophageal body and the upper esophageal sphincter, and you want to exclude scleroderma. It can also be used in the evaluation of non-cardiac chest pain, and it has its role in excluding the GI involvement from scleroderma and other diseases. So let's look first at achalasia. In achalasia, really the abnormality is in the relaxation of the lower esophageal sphincter. And this may approach zero, And they now accept LES that goes to zero, but for a very, very short period. But most would say it's incomplete relaxation, that sphincter never drops to zero. It may be hypertensive, but later on in the disease, these sphincters can be 10 to 20 millimeters of mercury. The body has to have absent peristalsis, and early in the disease, when the disease is vigorous, it may be a hypertensive contraction. So here's the classic manometric tracing of a patient with achalasia. And here we can see that lower esophageal sphincter never really relaxes with swallowing. It always has a baseline pressure above zero. You can see that the esophageal body contractions are very, very small, less than 30 millimeters of mercury, and they are tertiary waves, or non-propulsive waves. So that's a classic trace of achalasia. Diffuse esophageal spasm is an interesting disease, but is really quite uncommon. The LES is usually okay, but it may be abnormal. But the definition of DES requires that greater than 10 to 20% of the waves be simultaneous contractions. They're usually repetitive. They can be quite prolonged. They're spontaneous. They do not necessarily, but they can be hypertensive. And intermittently, between all these simultaneous waves, you'll see normal propulsive waves. And here is a patient with a wet swallow that gets these simultaneous contractions. And here we can see after a wet swallow, we have a wave that is propulsive. Nutcracker esophagus, that was a very, very in vogue diagnosis to make in the mid-1980s. And it was felt that this is the major cause of chest pain, people with hypertensive lower esophageal bodies. Really, it probably is an epiphenomena that we see in people with severe reflux disease. I've seen it on a number of occasions in people who have failed hiatal hernia repairs with obstruction. And what we see is an abnormal body with hypertensive contractions, the mean of 3 contractions being greater than 180 millimeters of mercury. They may be of long duration, but underlying all this, you'll have normal peristalsis and probably a normal LES. And really, nutcracker esophagus is probably a epiphenomena, and you should probably never contemplate on operating just for the nutcracker esophagus. There may be reflux or some other problem causing it. And here we can see a wet swallow and the propulsive waves with these very, very hypertensive waves in the lower esophagus. And here you can see the lower esophageal sphincter with the commencement of the swallow dipping below zero and returning to its normal resting pressure after the swallow. So the abnormality is confined to here, and it's probably a secondary phenomena, not requiring a myotomy or any surgical intervention. Hypertensive LES we see on occasion. There's a hypertensive LES with mild elevation of residual pressure, but a normal body, not like achalasia, where there's absence of peristalsis. There is this entity that, as surgeons, we very rarely see, called nonspecific esophageal motor disorder. And here there are abnormalities in both the LES and the body, with incomplete relaxation and residual pressure, and peculiar waves that don't transmit or have retrograde transmission that are very, very low amplitude and maybe quite prolonged. And here is the trace that you may see in a patient with end-stage scleroderma, a secondary motility disorder. And this is very, very crucial to obtain traces in these patients before you go and attempt to fix the reflux, assuming that they have a normal esophagus. And here we can see pharyngeal contractions with a wet swallow. As we go from the striated to the smooth muscle, you can see that there's complete lack of any pressure waves in that esophagus, and that's a dead esophagus that will not do well with attempts at repair. 24-hour pH monitoring is kind of the gold standard with which we must study our patients who have presumed reflux esophagitis. For not only does it quantify the amount of acid reflux, it also helps us identify those patients with atypical presentations of GERD. And I think that 24-hour pH monitoring has really replaced most acid stimulation tests, because as well as getting a 24-hour trace, you get a endogenous acid stimulation test. And here we have a little recording box with a probe is here, and this is a reference probe that's worn on the skin. And this is placed in the esophagus 5 centimeters above the LES. And the patient wears this for a number of hours, classically 24 hours, but there is shortened 8-hour ambulatory measurements as well. And what you have to do is look at the tracing. And this is a normal physiologic trace that we would see in an average adult. And usually the pH will stay above 4. But here you can see in the daytime, especially around lunch and dinner, there are short episodes of reflux that clear very, very well. And when the patient is sleeping here, in the supine position, there's no reflux. Upright refluxers are people who reflux during the day, but have no reflux at night. And you have to be very, very worried about these people when they're sent to you where they have pure upright reflux. These people do poorly with hiatal hernia repairs. They're usually people who are gassy and belchy and have colonic dysmotility, and they're really making all that reflux by regurgitation. And so these people do miserably with anti-reflux procedures. And what you want to see is somebody who has a combined reflux pattern. You can see they're refluxing throughout the day and even at night when they're supine. And what we'd like to see is, this is the percentage of the time when the pH is below 4. A median for the average patient is less than 1% of the day is spent with the pH less than 4. The majority of that is in the upright position, is very, very physiologic and in response to meals, cleared very, very easily. There should be minimal supine reflux. The average patient has about 18 reflux episodes a day, none of those longer than 5 minutes, with the longest being 3 minutes. And when it comes to diagnosing gastroesophageal reflux disease, there's no doubt that 24-hour pH monitoring is very, very sensitive. EGD is sensitive, and with the addition of biopsy, which has nonspecific changes of inflammation, can approach 75 to 80%. And barioesophagram is about 40% sensitive in the diagnosis of gastroesophageal reflux disease. Provocative tests, cholinergic stimulation of primary motility disorders, achalasia, with cholinergic agents can cause a paradoxical increase in contraction, and that seems to have been outdated with our other studies that we have now to study esophageal motility. And acid perfusion for patients with gastroesophageal reflux disease, I think, has been replaced with 24-hour pH monitoring, which has a built-in acid perfusion test. One thing to remember, we can do nuclear studies. This is a nuclear study in a patient with achalasia, and these are minutes. And you can see that the radioactive tracer stays in the esophagus for up to 120 minutes. That should clear within 8 to 10 seconds. But probably esophageal transit times are not that helpful to us. It's more important to do gastric emptying studies in patients who have abdominal symptoms to suggest gastric outlet problems, because indeed some hiatal hernia repairs may be unsuccessful because of the lack of recognition of distal motility disorders. Thank you very much.